Professor Shimizu. This patient is a 73 years old male with tardy paralysis following vertebral body collapse caused by osteoporosis. This condition is generally called as Kummell disease. About the chance when we meet a patient with Kummell disease, Dr. Shen of Taiwan said, a non-win situation because when we do not surgery, we are blamed, and when we do surgery, we also blamed. Kyphotic deformity of Kummell disease causes big problems of low back pain and neural compression and damages both patient and spinal surgeons. Emeritus Professor Kokubun of Tohoku University has developed the new method of surgery of spinal shortening for lumbar degenerative kyphosis. We did it in 10 cases. We also performed the spinal shortening for burst fractures in 20 cases. This slide is showing the X-rays and MRI before and after surgery of a case of a 38 years old male. Advantages of our spinal shortening are high correction rate for kyphosis, little correction loss after surgery, short fusion and body-to-body fusion. We did spinal shortening for Kummell disease in 15 cases. In this presentation, I would like to talk about the methods and the results of the surgery. Surgical methods consist of two parts, that is, excision of posterior fragments of vertebral body and intervertebral disc, and correction of kyphosis with pedicular screws and laminar hooks. For Kummell disease at L1 vertebral body, firstly, the sites for laminar hook insertions are prepared at the upper end of T12 and at the lower end of L2 lamina. Then pedicle screws are inserted at T12 and L2. And the lower half of T12 lamina, facet joints, total lamina of L1 are removed. Then both pedicles of L1 are removed. Next, upper part of the L1 vertebral body, the intervertebral disc between T12 and L1, and the posterior longitudinal ligament are removed. Rods are constructed, spinal shortening is done, and the laminar hooks are inserted finally. Just after positioning the patient into prone position, we routinely take an X-ray of a lateral view and measures the angle for the osteotomy. Sagittal alignment of 0 or more lordosis should be accomplished at the osteotomy level. Plain films before and after surgeries are shown. This patient is a 75 years old female of Dennis type C. In this case, lower part of L1 vertebral body and the disc between L1 and L2 are compressing the dural canal. MR images are also showing the lower part of L1 vertebral body compressing the spinal cord. For this case, the lower part of the vertebral body and the intervertebral disc between L1 and L2 were removed. Remaining upper part of L1 body has a contact with the L2 body. Plain films before and after surgery are shown. L1 body has a contact with the L2 body. Patients are free at 2 weeks after surgery, but they have to wear the hard brace for 6 months. In our series, operation time averaged 6 hours and 30 minutes. Blood loss averaged 1,100 milliliter. Length of shortening averaged 19 millimeter. Now, next I'd like to show the surgical result about complications, low back pain. Follow-up periods averaged 2 years, 9 months. Post-operative complications happened in 3 cases. Revision was done in all these cases. In 2 cases, chance fracture occurred at 4 and 7 days after surgery, respectively. In 1 case, total paralysis occurred just after surgery due to inadequately resected lamina. This is a case underwent revision surgery. The patient was 65 years old male with malignant rheumatoid arthritis. Collapsed vertebral body level was T12. Chance fracture happened at 4 days after surgery. Revision surgery was done and posterior instrumentation and stabilization was done at T9 through L2. In this case, at the first surgery, I mistakenly removed the interspinous ligament between T11 and T12. Preservation of posterior ligamentous complex is very important to prevent the chance fracture of the upper adjacent vertebral body. This case also underwent revision surgery. The patient was 3 years old female. In this case, at the first surgery, I remained the lamina too much. Then the spinal cord was compressed between the remaining disc anteriorly and the lamina posteriorly. Through revision surgery, I removed much more part of lamina. Cutting line in lamina at the level same of upper to lower end of vertebral body is important to prevent the compression after shortening. Other key points for successful surgery are preservation of posterior ligamentous complex and resection of incision of the Callus, and application of hook and rod system. We have to remove or at least incise the Callus at the site of vertebral osteotomy. Otherwise, we cannot perform the shortening later. Japanese Orthopedic Association scores of low back pain were improved in all cases after surgery. This is a case of a 75 years old male. Collapsed body level was L2. In this case, a lower part of the vertebral body and the intervertebral disc between L2 and L3 were removed. Preoperative low back pain was disappeared, and good results were obtained at 2 years after surgery. Preoperative paraparesis was also improved in all cases. That is, motor weakness on manual muscle testing was improved in all cases. This patient was a 71 years old female. Collapsed vertebral body level was T11. She could not walk before surgery, but Her gait disturbance was improved after surgery. She could walk without any support at 1 year after surgery. Gait disturbance before surgery was improved in all cases after surgery. For instance, on the 6 cases who were unable to walk, 2 cases became able to walk without support. 4 cases became able to walk with a stick. This patient was 60 years old female. Collapsed vertebral body level was L1. She had a concomitant vertebral body fracture at T11. Pedicular screwings were added at T10. Good results were obtained at 2 years after surgery. Bony fusion at the osteotomy site was obtained in all cases. This is a case showing the completion of fusion 6 months after surgery. This is a case showing the bony fusion at the disc level. This is a case also showing the bony fusion at the disc level. Oblique views are generally very important to know the fusion at the disc level. New or added fracture occurred in 5 cases after surgery. Fracture occurred at the end of instrumentation in 2 cases, at the adjacent in 3 cases. This is a slide showing the bony fusion at disc level. This is a slide showing new added fracture. And kyphotic angles averaged 38 degrees before surgery and averaged 5 degrees just after surgery and averaged 14 degrees at the final follow-up. The correction rate, the correction was well maintained except for 1 case. Conclusions. Spinal shortening is useful for Kummell disease. Sagittal alignment of 0 or more lordosis should be accomplished at the osteotomy level. Not epidural vein control, but vertebral body resection should be first for the reduction of blood loss. Preservation of posterior ligamentous complex is essential. Our method of spinal shortening for Kummell disease can correct kyphotic deformity well and attain certain neural decompression. Our method can provide enough improvements in low back pain, neurological deficits, and gait disturbance. Thank you for your attention.